Yeah, thanks for that. And I am going to, in a very informal way, try and just review what I feel like are um, the more pertinent clinical trials going on in the CLL world at this point, and some of which have maybe recently reported out and resulted in some changes that impact patient care. Some of which, that have yet to report data, but we're all, watching closely. And that, but before I go into too deeply what's on the horizon, what's changing, what hasn't changed really in decades is the approach to a CLL patient without symptoms. And I always just want to review that this is still a most of the time what we call indolent or slow growing lymphoma. So about half the time patients get diagnosed, they don't have any perceived problems that the disease is causing. And we are still at this point in 2025 still just watching those patients. We know that there's a portion of those patients that present with a what we call an incidental diagnosis that never end up needing treatment. So we don't want to overtreat. We are doing a great job when we do treat CLL patients. In fact, recent data has shown that in this era of targeted treatments that most of you are aware about, that we have normalized life expectancy of CLL patients. I always make sure when I see a new CLL patient that I mention that point, because we don't want to over in a setting where we have enough treatments where it looks like at a large population level CLL is not impacting life expectancy. We want to make sure that we're not over treating, and we use the treatment for those that need it. Luckily, we have some very good ones. Of course, that's why patients are not having their life expectancy um, uh, affected in most circumstances. And the list is growing, and that's what I'm going to talk to you all today about. But just a real quick, rehash for those that are wondering, does my CLL need treatment? Yes or no? The objective findings are easy. Is the CLL taking up too much of my bone marrow? Is there anemia, hemoglobin less than 10? Are the platelets less than 100? Are the lymph nodes bothering me? Now we've moved into more of a subjective, so that's you telling the oncologist that things are bothering you enough that you want to embark on treatment. Um, so yeah, lymph nodes are bothering me. I'm waking up drenched in sweat regularly, and it's disrupting my quality of life. Uh, Fevers and weight loss are on there, but that's something I don't see too often with CLL. Honestly, that's something that makes me think about more aggressive lymphomas. And then finally, fatigue is on there. It really should be, if not connected with another problem that the CLL is causing. The fatigue, how we try to objectively quantify it is it's making people spend half the day or more just resting because they can't do what they need to do. And it's interfering with quality of life and the normal activities of daily living. And we can't figure out another cause. So those are why we treat. With the exception of maybe the fatigue, we can pretty easily fix all those problems I just listed with our treatments. As a baseline of where we are and where we've been for a few years, it really all started to change with BTK inhibitors. We've got some different kinds of BTK inhibitors now. The original was ibrutinib, and there might still be some people listening or on this call that are still on ibrutinib. It's a really good drug. It's just that we have now come out with essentially more specific kinds of ibrutinib. Acalabrutinib and zanubrutinib were approved sequentially within the past few years and have been compared head to head to ibrutinib and shown to be, in the case of acalabrutinib, better tolerated. In the case of zanubrutinib, actually better tolerated, and it kept people in remission for longer when it was looked at in a relapsed patient population. So it's not that we had to go out and stop everyone that was on ibrutinib and put them on something else, but I personally, based on some data, have taken my long-term ibrutinib patients that weren't wanting to switch, and I've reduced their dose to at least 280. There's a lot of data that shows that the long-term side effects of ibrutinib um, are much diminished and even absent at the lower doses, and it doesn't impact long-term outcome. So we're not, if you look at the national guidelines, we're not really supposed to be starting new patients on ibrutinib anymore because we have acalabrutinib and zanubrutinib. Those are both felt to be equivalents of each other, acalabrutinib and zanubrutinib, equivalent options, and they represent sort of the marathon treatment approach, as I call it. The other target that we have available to us, the oral targeted agent, is venetoclax, and that is a BCL2 inhibitor, and it is always paired with an antibody, which in the majority of circumstances should be a drug called obinutuzumab. And that's what I call the sprint approach to addressing CLL. You know, the BTK inhibitors, acalabrutinib, zanubrutinib, require indefinite treatment, daily dosing. The venetoclax and obinutuzumab, you just take the combination, in the total combination lasts about a year, and you stop as a first line treatment. You're able to retreat later. I'm laying this as a groundwork, not because I'm going to spend the whole time just educating us on what we are doing in CLL or what we've been doing, but just to sort of use it as a springboard of where we are now going. Because the big changes that I want to highlight, because it's going to affect most patients, are what we are doing in the first line setting. You know, thankfully, I'll talk about towards the end that we have new drugs becoming available in the third line plus setting, but our first and even second line treatments are doing so well. The majority of CLL patients aren't ever going to need anything third line, fourth line, but thankfully we're going to have some treatments for those patients if they do. So the biggest change that has already come into play in terms of national guidelines being updated, but has not yet resulted in an FDA approval, is the use of acalabrutinib with venetoclax, with or without the obinutuzumab monoclonal antibody. So that was based on the Amplify clinical trial that was just published this year, and the data was presented at ASH at the end of last year. And it was a big study. We call it phase 3, where they compare the intervention to standard. So the standard that was compared to was chemotherapy, which we're not really using anymore. So no surprise that the acalabrutinib and venetoclax combination was better than chemotherapy, bendamustine rituximab, fludarabine cyclophosphamide rituximab. Both were worse than the acalabrutinib and venetoclax. So the advantage or the novel thing that this does is it now allows a proportion of patients, if so desired, to be given that what I call sprint based therapy, time defined as opposed to marathon, but doing it without IV. You can take the acalabrutinib and venetoclax that are both just pills. And of course, we've been using them a long time, and we know their side effect profile and they're effective. So you can use the 2 pills, take them for a year, and stop and never need IV treatment. Some patients do benefit from the obinutuzumab, the IGHV unmutated patients, which some of you that are familiar with the prognostic workup of CLL know that unmutated patients tend to progress more quickly on time-defined treatments. So adding the obinutuzumab seemed to really help those patients, but a lot of patients like those that are mutated at IGHV didn't necessarily need the obinutuzumab. So me personally, within the past 6 to 9 months, I've really totally changed how I'm managing my first-line CLL patients, which is going to be the majority of my patients. You know, when I'm not putting these patients on a clinical trial, I am prioritizing time. I've always sort of prioritized time-defined therapy, but now I'm able to convince more patients to buy into that because a lot of them are okay with doing 2 pills as a time-defined therapy. Historically, I would try to convince a lot of patients to do the venetoclax and obinutuzumab, but the patients would weigh that option with the IV infusions versus just taking a pill like zanubrutinib, and they would opt just for the ease of taking a pill by itself, even though it was given indefinitely. So that's been the biggest change that I've seen based on a recent clinical trial. The moving beyond covalent BTK with acalabrutinib or zanubrutinib and then venetoclax, that's the standard, whichever order you want to go in, first and second line treatment for CLL patients these days. And then now with the combinations, you can re-challenge if you've had a treatment-free interval. It looks like the CLL still responds to giving the same venetoclax-based treatment again, which is great. So then the research that's changing or on the horizon that might change this first-line treatment even more is other combinations with BCL2 inhibitors. For example, there are investigations with pirtobrutinib and venetoclax, and we'll wait and see if that looks better than acalabrutinib and venetoclax. For those of you that need a little refresher, pirtobrutinib is one of these FDA-approved third-line plus treatments. Maybe we can even use it second line in some circumstances now. But it's a little bit, it sounds like ibrutinib, acalabrutinib, and zanubrutinib, but unlike those drugs that all inhibit BTK in the same way, pirtobrutinib is a non-covalent BTK inhibitor that still works in patients that have progressed on ibrutinib, acalabrutinib, and zanubrutinib. It still works most of the time. And so they're looking at, can that be used as a first-line treatment with venetoclax, maybe, or as a second-line treatment, and with venetoclax, and I've participated in those time-defined studies. So we'll await data from those trials to see if there's a role for earlier use of pirtobrutinib. The venetoclax has been on its own as a BCL2 inhibitor since it was approved since 2016. That's a very different story. I've talked about all these BTK inhibitors that we have to choose from. But venetoclax is the only BCL2 inhibitor. Well, that's going to change within probably the next 1 to 2 years. We're going to have what's called, a next generation BCL2 inhibitor, and it's called sonrotoclax. That drug is being developed in many different formats to challenge and maybe replace venetoclax down the road. We will see how the data ultimately looks. The early, single agent data is promising, and there's some thought that it might be effective in certain resistant mutations that patients have that progress on venetoclax. So we'll have to see if it looks better than venetoclax down the road. But in the same way that acalabrutinib and venetoclax is now a category 1 or a top recommendation on national guidelines as a frontline treatment, we will see if how zanubrutinib with sonrotoclax looks, and that's a big first line trial that we're all going to be interested in seeing the results for. There's also sticking with that acalabrutinib venetoclax combination. There's interest in trying to personalize treatment to the patient and not just treat everybody the same. I put a whole lot of patients on this trial called the MAGIC trial, and we're awaiting for our first data readout that might, happen in about a year or so, I would think. But it looked at using MRD or minimal residual disease testing after 1 year of acalabrutinib and venetoclax, and taking the patients where we could still detect MRD and giving them another year of treatment versus those that we do not detect MRD, stopping that treatment. And there's a comparator arm with just the standard of care venetoclax or obinutuzumab on that study. So that study is going to be really interesting in a couple of ways. It's going to, one, tell us how acalabrutinib venetoclax compares to venetoclax obinutuzumab, which will be a really interesting thing to look at. But also it will tell us, does using MRD seem to make sense? And for those that need a little refresher on what MRD is, it can be done in the peripheral blood, which is really nice. You can do it in the bone marrow, but most of the excitement surrounding MRD is looking at how deep a patient is responding to treatment without having to do a biopsy. And it looks at even to a sensitivity of if you take 1 million white cells, you can see 1 CLL cell potentially. Most use the cutoff at 1 in 10,000 as calling somebody undetectable, but we can even go down to 1 in 1 million now. So most novel clinical trials that are using time-defined therapies are looking at MRD as a way to assess how deep patients are responding. So we'll see if we can one day use MRD to decide who needs longer treatment, and that'll be very interesting. Moving outside of the first line / second line arena where it's BTK BCL2 combinations that are dominating, it's clear we need more options than just pirtobrutinib as a third line agent. Pirtobrutinib, it works for most patients, but if you've seen a BTK inhibitor in venetoclax already, the average patient's probably only going to respond around 1 year to pirtobrutinib. So we need better options than that, because just as a frame of reference, if you give zanubrutinib or acalabrutinib as a first line treatment, those patients are probably going to respond for 10 years reasonably. So can we get really good outcomes like that in the third line plus setting? One class of drugs, there's a couple, 3 that are being developed all and are racing to get approval, is the BTK degraders. So we keep coming up with more treatments for targeting BTK. We've got the covalent BTK inhibitors, 3 of those, ibrutinib, acalabrutinib, zanubrutinib. We've got the non-covalent pirtobrutinib. Well, the degraders are coming, which just sort of dissolve the whole protein instead of inhibiting it. And so preclinical, or well, I should say early clinical data shows that they're effective at a lot of different mutations. So the mutations that are leading to pirtobrutinib resistance, the degraders still work. And so there's some that are actually interested in challenging pirtobrutinib head-to-head. So there's some head-to-head studies of degraders versus pirtobrutinib under getting started, but initially we'll likely get degraders approved as an additional target that we can go after in the third line plus setting as single agent. And then we'll see if those compounds are interested in combinations. You know, before I conclude and go to, questions and answers, I think we've talked a lot about targeted treatments and mostly oral therapies. Um, in other areas of lymphoma, which I do treat all types of lymphoma, of course, we've been using the immune system really effectively to completely eradicate lymphomas, so cure lymphomas. I know we don't talk about cure all the time or very often. When it comes to CLL, we see it more as a chronic disease that you manage over time as needed. But we do think, we historically know that some young CLL patients, many years ago when we didn't have good treatments, they would get stem cell transplants and new immune systems would come in and cure those patients in a lot of circumstances. But stem cell transplants are highly, risky undertakings and can only be done in patients that are usually a lot younger than the average CLL patients that's seen several therapies. So can we find a way to use the CLL, to use the immune systems to attack the CLL in a more safe way? We actually already have CAR T approval for third line plus CLL patients. It's not something we have to use that often because taking a pill is a lot easier than doing CAR T therapy. Unfortunately, although we've had really excellent success with CAR T therapy in a lot of different kind of lymphomas, the efficacy in CLL is not as good. It's maybe only about a third of these patients optimistically are getting into complete remissions and can hope for long-term remissions. We're finding that it's just the immune system of CLL patients is so fatigued that developing CAR Ts from them aren't as effective. But we're finding maybe doing some different things with CAR T might increase their efficacy, so stay tuned on that. But an easier way to get kind of that immune system effect um, is bispecific therapy or T cell engagers, and we also have approvals of those agents all over different lymphomas. We don't currently have approval in CLL, but there has been data that's promising with a drug called epcoritamab that we use in other lymphomas, early phase clinical trial data. And that is an antibody sort of like rituximab that some of you might be familiar with, or obinutuzumab, but it's bispecific. It's not just a monoclonal antibody, so it hits the same target as obinutuzumab and rituximab, but it also it has a T cell engager attached to that, so it sort of brings the T cells into close proximity to the cancer, and it's an pretty easy subcutaneous infusion or injection, I should say, and appears to be quite effective. In fact, its remission numbers appear to even be better than CAR T for CLL patients. So that's going to be very great to have. We just have phase 1 data at this point, but I believe we'll eventually get approval from the clinical trials that are developing in that space. And I think there will be some interest in using bispecific antibodies with maybe our oral targeted treatments eventually earlier in lines of therapy and seeing if we can totally eradicate CLL with maybe a earlier use of combination treatment. So I've taken up about the first 30 minutes or so talking about what I think are the biggest developments in CLL, some that have already kind of resulted in guideline changes, some that are coming imminently, in terms of potentially new drugs becoming available or new combinations. So I'm happy to take questions now.
Yeah, that was super interesting and encouraging to hear so much work that's being done. And as Dr. Jacobs said, now is the time for questions. So if you have a question, feel free to type it in the chat or go ahead and use the little raise hand thing. And if you want to ask it verbally, you can do so that way. But I did have a pretty general question to start us off. But who would you recommend look into a clinical trial as a CLL patient now? You mentioned that a lot of the therapies that we have are really effective. So what types of patients should be looking into clinical trials at this state?
So there is data, just like, if you were to go, if you needed uh, to have a something as simple as like a hernia surgery, um, there's plenty of data in the surgical field that shows that if you go get whatever procedure it is, but for example, hernia surgery from somebody that all they do is do hernia repairs, the complication and failure rate is lower than if you go to a general surgeon. So the value, if a CLL patient at whatever point they are in their disease, if you have the ability to integrate your care with a CLL specialist. Doesn't mean you always have to see a CLL specialist, but if you can have a CLL specialist to at least weigh in on your care, the data shows that CLL patients live longer that go that integrate a CLL specialist into their care. And part of the reason is we get to just focus on all these things that I just talked about. But the other thing, and so we know the most up-to-date treatment and data, but the other part of it is access to clinical trials. Because I think, any CLL patient that needs treatment should be considered for a clinical trial, whether it's first line but the obvious patients are those that have seen multiple lines of therapy. And so, yeah, I would encourage before starting treatment for any line of therapy, if you can touch base with the CLL specialist, and there's different resources to identify where a CLL specialist is, in your area. But having the ability to touch base with a specialist is great for both getting the best recommendation from the most up-to-date data, but as well as potentially getting to hear about a clinical trial. What a lot of patients don't necessarily know is in most circumstances, when you go on treatment with a clinical trial, your treatment is actually covered by the clinical trial, the treatment itself. Not every element, not all the scans, not all the visits or anything like that, but the actual treatments, which can be so expensive in the current, healthcare environment, they are covered by the clinical trial. And a lot of times it's these trials like I was just describing to you that are using treatments that have already been FDA approved for a long time, and they're just looking at giving them together. So these aren't necessarily even experimental, so to speak. These are drugs that have a great track record and are just being looked at in a different way. And so it's a great way to get access to those treatments and have them provided for you.
Okay. And I am going to launch a poll right now. And this is about clinical trials, just asking how do you find clinical trials if you're eligible or if you've ever participated in a clinical trial. So that'll be launched for members of the audience. And then we'll touch base on that in a moment. But our next question is, what is the best current treatment for high risk patients? I'm in watch and wait, but I have 17p deletion and TP53 mutation. Just what are
Mhm.
they like? Kind of what's the standard there?
Yeah, yeah, it's a patient population in the untreated state that represents about maybe 10 to 15% of CLL patients, the chromosome 17 aberration patients. In the relapse setting, that goes up a little bit. It's a higher proportion. We It's hard to get 100% consensus, but I would say there is almost uniform consensus that an acknowledgement that the chromosome 17 aberration patients, their remissions on time-defined therapies are much shorter. Um, it looks maybe like with indefinite BTK inhibition, and the strongest data is with zanubrutinib, that the outcomes don't appear to be different with first-line treatment, whether you have a chromosome 17 aberration or not. And I mentioned, the PFS for first-line zanubrutinib, for example. It's when you look at the curves, it's reasonable to think, the progression time, the time to, first progression on zanubrutinib as a first-line treatment could be around 10 years. So that's unbelievable for a chromosome 17 aberration patient, where historically chemotherapy would have only gotten about a year of remission. So we've improved that 10 times over. So it's really great when you have breakthroughs like BTK inhibition that benefit everyone, but benefit the patients the most that were doing, really poorly with chemo. So you would, from most specialists, and this actually hasn't changed in many years. You would get the recommendation for indefinite treatment with a BTK inhibitor for your first line treatment choice with a chromosome 17 aberration patient. There, again, the data is strongest with zanubrutinib, but acalabrutinib isn't a wrong choice for this particular patient population. The watch and wait, though, there are, like it sounds like this patient is, there are, some patients that with chromosome 17 aberration that are not symptomatic at diagnosis. So there's no difference in the treatment guidelines based on your prognostic workup. It still is, if you're not symptomatic, you don't treat those patients. So it still would be wait for symptomatic progression. And there are, some rare chromosome 17 aberration patients that do have a more indolent course and can stay on watch and wait, or what we like to call active surveillance for many years.
And then, in a similar vein, the next question up is, are these newer treatments further leveling the playing field for IgHV unmutated patients?
Yeah, I mentioned that. So we also know that to not as much of a dramatic difference though, but in general, unmutated patients also do a little bit worse on time-defined therapies, whether it's venetoclax obinutuzumab or acalabrutinib venetoclax. But but with indefinite BTK inhibition, it doesn't seem to matter if you're mutated or unmutated. You're not going to necessarily hear many specialists that say, though, that unmutated patients should not get time-defined therapy. The difference is not as dramatic in outcomes as they are with chromosome 17 aberrations. So it is still very much okay to get venetoclax obinutuzumab as an unmutated patient. But what's newer is, and we're talking about first line therapy. What's newer is for unmutated patients, this Amplify trial that I talked about. Yes, you could get acalabrutinib and venetoclax, but the unmutated patients are not going to respond for as long. It looks like, though, if you add the obinutuzumab, which seems to be reasonably safe, particularly in the under 70 patient population, that triplet therapy seems to do amazing for unmutated patients, and it takes away that negative impact of the unmutated status.
Okay. And then our next question is, this is a really interesting one. Are you aware of any clinical trials that are looking at AIHA, which is, I believe, autoimmune hemolytic anemia, treatment in CLL patients who are treatment naive for their CLL. I wonder if there's benefit to not treating the indolent CLL early if the reason to start therapy is due to AIHA.
Yes. So I was trying not to get too much into the the weeds of just the background of CLL treatment because I wanted to save time to talk about the trials. But when I was talking about the indications for treatment, I mentioned anemia, hemoglobin less than 10. Usually in a CLL patient, that anemia is going to be because the cancer is taking up too much of the bone marrow space, and the bone marrow can't keep up with making up enough red cells. Sometimes the reason for the anemia, and you can tell by some complicated mm, changes can be subtle in the blood work, but sometimes the anemia is actually from the immune system attacking the red cells. We call it autoimmune hemolytic anemia or AIHA. Um, People without CLL get that too. It's just more common in patients with CLL than it is without CLL. It has been found if you treat the CLL, that goes away. But you don't necessarily have to treat the CLL all the time. The standard intervention in somebody without CLL that gets AIHA is to give them steroids. And that's generally a protracted multi-week course of something like prednisone. And you can do that in a patient with CLL. The downside is steroids tends to drive the white blood cell count up a bit more, so you just have to be ready for that. Um, Personally, I have found that while steroids are effective, they generally don't fix the problem long term, and the autoimmune hemolytic anemia does start to happen again. Um, and not a very long period of benefit from the steroids just by themselves. So I feel like it just ultimately delays treating the CLL if you start with the steroids. So I'll generally just go ahead and offer patients to start treating the CLL, but also offer steroids if they would prefer. I have not seen any clinical trials specifically looking at any other, non-CLL directed therapy interventions for that specific patient population, the CLL patient with autoimmune hemolytic anemia. Um, Luckily, our newer targeted treatments seem to work quite well at fixing the problem. The caveat is when it's something that happens in a patient that has seen multiple lines of therapy already, um, it's very difficult to control, and that's an unfortunate situation that's prognostically pretty rough.
All right. And then this next question is asking about if there's any clinical trials to see if BTK inhibitors can be a fixed duration as opposed to ongoing duration therapy.
Yeah, so that was what I spent a lot of the first um, of my talk talking about. And of course, that all centered around combining them with a BCL2 inhibitor. I think what this patient might be asking is, what about, all these patients that are on single agent BTK inhibitors and have been on for years? Um, we know that you can't there's not really any trials that are trying to recruit patients that are just going to give a BTK inhibitor by itself for a certain period of time and then stop. Because what we know from data in general is most patients, when they're on a BTK inhibitor, if they stop for like a side effect or something like that, the average patient will progress um, in about 2 years. So uh, that's okay. If a patient has to stop for a side effect, you don't need to necessarily hop right back into another kind of treatment. You can take a break, especially if you've been on a BTK inhibitor for a while and you've had a good response. And then you can consider, getting treatment with a different BTK inhibitor down the road, or switching class treatment when you need it. What there is some research looking into is not taking, treatment naive patients and giving them a single agent BTK inhibitor and stopping after a certain period of time. But it's looking at, what about these patients that have been on BTK inhibitors? Can you um, maybe come in and add a short course of something like venetoclax and get the patient off treatment? So there's been some look at those patients and intervening in that way. Yeah, so if I do think it's reasonable, if you've been on a BTK inhibitor for a while and you've had a good response, given that we now on guidelines have the combination of acalabrutinib and venetoclax approved. Um, the insurance approval has been good for me. I haven't had any issue. So if you really have a strong inclination for wanting to get off a BTK inhibitor, I mean, you could inquire to hematologist about adding venetoclax and taking a course. That's a little bit what we call, I mean, that certainly is what we would refer to as off-label. But you
Mhm.
could, with current guideline updates, you could probably get away with it. Just stopping the BTK inhibitor, though, it's just a question mark. We don't know if that's going to impact long-term outcomes at this point.
Good. And it looks like our questions are slowing down, but I did want to revisit our poll results.
Okay.
Um, so it looks like most people are saying that they're finding their clinical trials, if they are interested in them, through their oncologist, a CLL specialist, or clinicaltrials.gov. And we do have a couple members of our audience that have been on clinical trials. Um, so there is definitely some interest here about finding those and getting onto a clinical trial. Obviously, speaking with your specialist is wonderful. And I did want to let everyone know that HealthTree does have a clinical trial finder where if you have your medical records connected, it can help kind of sort through all of those to figure out which ones you could be a good candidate for. So we recently launched this. So if you have your medical records connected and you're curious about clinical trials, highly recommend checking it out. It's a really cool, new, powerful tool. Um, but as always, checking with your specialist is always a very good option. So, um, yeah, I think looks like we're out of questions. So, just do you have any closing remarks that you'd like to tell the audience about clinical trials?
No, well, I mean, I did kind of cover some of the benefits, um, maybe beyond what people think. The obvious would be potentially access to something better than you could get access to outside of a trial. Um, the um, the other kind of less maybe well-known benefits is sort of like I described earlier, is getting something that really isn't even necessarily experimental. A healthy number of CLL trials these days are using drugs that we've had approved for quite some time, and just sort of using them in a different way. So it's sort of it takes the question mark out of, is this going to be effective, or is this going to be well tolerated? Um, and so that's great. And then an additional element, probably a lot of people don't realize, is you get access to um, um, a research nurse that, every patient that comes into my clinic, of course, they have me and they have my regular clinic nurse, but clinical trial patients get an extra nurse that follows them around. Every trial patient has to have an assigned research nurse. So it's an extra set of eyes, and it's an extra person that you can reach out to. that they've actually shown, when patients get standard of care, a lot of trials um, had a standard of care arm, so get something that you could easily get outside of a trial too, so they can compare the new treatment that they feel it might be better, to the standard. Um, and so even patients that get standard of care, you might be sort of bummed out that you didn't get the interventional arm, but if you're getting standard of care on a trial, again, a lot of time it's paid for, even though it's standard of care. So there's that financial benefit, but then also you get a research nurse, and they've looked at it, and people do better on standard of care on trials than outside of trials. So that's another sort of not well known benefit. Probably has a lot to do with the extra supervision that you get from the research nurse.
I think that's something that I didn't know, and I'm sure a lot of people in the audience didn't know. So thank you for sharing, and thank you for spending your time with us, both presenting and answering questions. It was wonderful to work with you again.
All right. Yeah, thanks for having me, and thanks everybody for the great questions.
All right. And as we start to wrap up here, I just want to remind everyone about that short survey that we have at the end. You can leave feedback about today's event as well as suggest some topics that you'd like us to see cover in the future. And I want to let you know, so September is a very busy time of year here at HealthTree because this is Blood Cancer Awareness Month. And with that, we've got quite a few events coming up. So tomorrow we have Staying Covered, Navigating Insurance Changes When You're Living with Blood Cancer. And then on September 10th, we have Taking Charge After a Blood Cancer Diagnosis, What Every Patient Needs to Know. And then on the 19th, we have Finding Strength After Setbacks, Real Stories from Relapsed and Refractory Blood Cancer Patients. So we'll be doing quite a bit for the blood cancer community during this month of September. So if you're interested in any of those, I highly encourage you to register for them and check them out because there should be some really good events. And then again, big thank you to our CLL sponsor, AbbVie. Truly would not be able to host these types of events without them. And finally, I just want to say a big thank you to everyone for attending today and being part of our CLL community. Um, Again, thank you, Dr. Jacobs, for spending your time with us. It was wonderful having the chance to speak with you again. I've included my email here on the slide so that you can reach out to me if you ever have any questions or need any help. I'm always available to members of the community. And I'll go ahead and stick on for a couple moments if anyone wants to talk with me or talk to anyone else in the community, but I'll go ahead and wrap up our formal part of today's event. So if you need to hop off, thank you. If not, I'll go ahead and shut the recording off and we can get to chatting. Thank you, Dr. Jacobs.